Thank you very much. As you mentioned, my name is Dr. Arthur Wood. I'm an otolaryngologist with Foothills ENT that has offices both here in Easley and in Greenville. And I've been asked to talk today on the fairly broad topic of thyroid disorders. And so, is there some way I can, Andrea?
Yes, sir.
Is there some type of microphone or something?
Yes, sir. Thank you. Put it up in your lap. No, there's no phone. Brad, let me get a key. See, he's not as loud as I am. Thank you, Andrea. Go, pretend like you're red. See here, you got a card.
While she's while she's doing that, I'm gonna do a little preliminary work here. Well, I failed 6th grade art, so that's why I'm here. So, but I was going to wait until I have the benefits so everybody can hear. I'll tell you what, folks, I'll go ahead and get started. I'll try to speak up, and when I get some auditory help here, we'll go on from there. Can everybody hear me now? Can you hear me now? Okay. All right. I've been asked to speak on the thyroid, which is a fairly broad topic, and so what I thought I'd do in the time that we have is I would talk to you first about what the thyroid gland is, what its actual function is, some of the medical issues that are involved with the thyroid, and then finally I would start or finish with some of the surgical aspects of the thyroid gland, which is what I'm most involved with.
Wire you a little bit more.
Okay.
And the closer that one is to your mouth, the better it's going to be.
Can you hear me?
Is that any better?
Is that any better? Not really. Well, I'll do my best to speak up for you, ma'am. Okay? I said I would finish with what is commonly done for surgery on the thyroid gland, which is primarily what I'm involved with. Usually with thyroid disorders, the medical management of the thyroid difficulties, such as hyperthyroidism or hypothyroidism, is usually handled by an endocrinologist who handles that and along with other endocrine disorders. I become most involved when there are conditions, both benign and malignant, that may require surgery. But I'll start by saying the thyroid gland is an endocrine gland and is one of the larger endocrine glands in the body. And the endocrine glands are characterized, there we go, by they're glands that actually secrete their products called hormones directly into the bloodstream rather than through a duct or some type of conduit. So some of the other endocrine glands that you may have heard of are things like the pituitary gland, the pancreas, the ovaries, the testicles, and the adrenal glands. And just from the sake of anatomy, the thyroid gland is located in the anterior or front part of the neck, just below the voice box and overlying the trachea. And its name is derived from the Greek word for shield because it consists of two lobes on either side of the trachea that are connected in the midline by a bit of thyroid tissue called the isthmus. And this thyroid gland itself is anchored to the larynx and trachea by a thick connective tissue ligament called the ligament of Berry. And that explains why when you swallow, this gland tends to move up and down. So if any of you have been at your doctor's office and they feel for your thyroid gland, they'll usually stand behind you, put their hands on the lower part of your neck and ask you to swallow. What they're trying to do is get that gland to move up and down and see if there's anything that they can palpate. Intimately associated with this thyroid gland are some other important anatomic structures. The first one that I want to talk about is the recurrent laryngeal nerve. There's one on each side that runs along either side of this trachea and inserts into the voice box at about this level right here. And it's an important structure because it's involved with, it innervates all the muscles of your voice box. So it's an important structure and one that's potentially at risk when you do thyroid surgery. And so, I bring that to your special attention because that's one of the things I'm concerned about as I'm doing thyroid surgery. The other anatomic structures that I'm worried about are 4 small parathyroid glands that are usually located on the back side of the thyroid gland, but sometimes they can be embedded within the gland itself, or they can be located in distant areas like down in the chest or up higher in the neck. And these are of concern because these small glands secrete a hormone called parathyroid hormone, which is involved in increasing the calcium level in your bloodstream. And these glands are at potential risk as well when you do thyroid surgery. And if they are inadvertently removed, or if you happen to destroy the blood supply to those glands, then what will happen is the calcium level in your bloodstream will drop precipitously. And that's a very worrisome problem because it causes irregular heartbeats and arrhythmias. So that's the biggest concern I have as I do this type of surgery. And I want to try to monitor that and make sure that it stays within a normal range. The purpose of the thyroid gland is basically, I liken it to the carburetor on a car. It determines how quickly the body uses energy. It's involved in synthesis of proteins, and it actually helps control how sensitive other body parts are to other hormones. And the primary hormones that are produced by the thyroid gland, there are 2 of them. One is triiodothyronine, more commonly known as T3, and the other is thyroxine, which is known as T4. And these hormones affect the rate of growth as well as the function of other body symptoms. The thyroid gland is also involved in secreting something called calcitonin, which helps reduce the calcium supply in the bloodstream, and together with the parathyroid hormone is involved in calcium metabolism. The thyroid gland itself is actually under the control of the pituitary gland, which sits at the base of the brain. So if we just kind of flip this over. So here's your pituitary gland, and it's secreting something called TSH. And the pituitary gland itself is under the subsequent control of the hypothalamus, which is located within the brain itself. And it secretes something called thyrotropin releasing hormone, or TRH. And so in patients that do have thyroid problems, there may be other issues that are involved because problems that affect the pituitary gland or the hypothalamus may secondarily affect the thyroid gland itself. And again, this is where I depend on my endocrinology colleagues to help sort some of these issues out. It can be very complex, and they're very skilled at those types of things. But the thyroid gland, which we had pictured before, again, secretes T3 and T4. And when the pituitary gland secretes TSH, or thyroid stimulating hormone, it causes the thyroid gland to increase the production of these hormones, T3 and T4. As these levels rise, they exert a negative effect back on the pituitary so that it causes it to shut down production of TSH. So that by this loop where this stimulates this and this comes back and has a negative feedback on the pituitary gland, we help keep thyroid levels in a therapeutic range. That's how it's monitored within the body. And monitoring these levels is very important as we look at different thyroid disorders. And in cases of where there's too much production of T3 and T4, we have a condition known as hyperthyroidism. If these levels are low, then we may have issues with something known as hypothyroidism. And within the gland itself, there can be growths or tumors that occur that may or may not be sensitive to these hormones. And all of these conditions, hyperthyroidism, hypothyroidism, and nodules or growths that occur within the gland can cause an enlargement of the thyroid gland, more commonly known as a goiter. And that's all that goiter means, is that it's an enlargement of the thyroid gland. In hyperthyroidism, as I mentioned, it's an overactive thyroid. There's an overproduction of the thyroid hormones T3 and T4. And the most common cause for this is a condition called Graves' disease, which is an autoimmune disorder where the body makes antibodies that actually stimulate the thyroid gland to secrete more of their hormones. And as this happens, the thyroid gland will enlarge as it produces more thyroid hormone and produces what's known as a toxic goiter. And the reason they call it toxic is because it's associated with the excessive production of T3 and T4. And the symptoms that we have associated with hyperthyroidism include that enlarged thyroid gland. You can have protrusion of the eyes that kind of stick out of the head, these bug eyes that is known as exophthalmos, palpitations, sweating, diarrhea, weight loss, muscle weakness, a sensitivity to heat, and often an increase in appetite. The treatment for this condition usually involves several different medications. One is a beta blocker, which is a medication that tends to block certain symptoms such as palpitations, anxiety, restlessness. Other medications that are used are tapazole and propylthiouracil, more commonly known as PTU. These are medications that actually start to shut down the production of thyroid hormone. And it can take months for these medications to come on board. And so and they're also associated with different side effects. So again, my endocrinology colleagues are the ones that come in and usually prescribe and monitor these medications. Some other treatments that might be available for hyperthyroidism include radioactive iodine ablation, where actually there is a radioactive iodine 131 is injected in the bloodstream, and it's selectively taken up by the thyroid gland and it destroys the gland slowly over time. And finally, sometimes we'll consider surgical resection of the thyroid gland itself, either partially or completely, to try to help with this hyperthyroidism. If I take the gland out completely, then we have the exact opposite happen. problems with hypothyroidism. And this is a condition where there's an underproduction of the thyroid hormones. And it can be caused by congenital thyroid abnormalities. It can be caused by iodine deficiencies, primarily in poorer developed countries. That's not very common here in the United States. Autoimmune disorders such as Hashimoto's thyroiditis, and that's thought to probably be the most common reason here in America. And it can occur if the gland is removed either for hyperthyroidism or if it's removed because of some type of thyroid cancer. The symptoms in this instance generally are weight gain, tiredness, hair loss, a sensitivity to cold, and a slowed heart rate or bradycardia. Treatment here generally involves thyroid hormone replacement, usually in the form of levothyroxine, or more commonly known as Synthroid. And this is a lifelong treatment and can take several weeks to get on board. In hypothyroidism, we can also have goiter formation as well. Because the thyroid levels are low, the pituitary again secretes more thyroid stimulating hormone in an attempt to get more thyroid production. And as this happens, the thyroid gland enlarges, but this results in what's known as a non-toxic goiter, because the thyroid gland is enlarged, but it's not associated with the production of thyroid hormone. There are certain conditions that may initially present with hyperthyroidism and then ultimately become hypothyroid. And the two most common here are Hashimoto's thyroiditis and postpartum thyroiditis. And Hashimoto's thyroiditis, like Graves' disease, is an autoimmune disorder where the body makes antibodies that actually combat or actually destroy the thyroid gland. And in the initial phases of this condition, as it's attacked, it becomes irritated and agitated and can produce more thyroid hormone. But as these antibodies destroy more and more of this gland, the patient will subsequently become hypothyroid. Postpartum thyroiditis occurs in women after childbirth. And what can happen here is that the thyroid gland becomes irritated or agitated for reasons that aren't completely understood and will produce an excessive amount of thyroid hormone and then may drop down to a hypothyroid state. And in some cases it may return to normal, but in others it may not. And just like hypothyroidism may require lifelong treatment with Synthroid. We don't really know the cause of postpartum thyroiditis. Again, it's probably postulated to be an autoimmune disorder, but we haven't figured that out yet. You know, I've touched on these conditions, and basically to give you some background, my endocrinology friends are the ones that generally handle these types of problems. You know, I become more involved when patients present for some type of problem that requires surgery on the thyroid gland. And there can be both benign and malignant conditions that are involved. Sometimes surgery is indicated for those patients that do have hyperthyroidism, as I mentioned before. And we might consider surgery in those patients that don't tolerate some of the medications that we talked about, or who don't tolerate the radioactive iodine treatment. And so either a partial or total removal of that gland may be necessary. Another reason why we may operate on thyroid glands may be if they become markedly enlarged. As I mentioned, a lot of these conditions produce an enlargement of the thyroid gland, and if it enlarges significantly enough, it may cause compressive symptoms on your windpipe and on the esophagus. And this is particularly true when the goiter tends to grow down into the chest and becomes what's known as a substernal goiter. And in these cases, when they're enlarged enough, they'll start to cause compression symptoms so that patients will have some trouble breathing, particularly when they lie flat at night. They may have some trouble swallowing. They may develop problems with hoarseness and a cough. And so again, either partial or total removal of the gland may be indicated in this case as well. The most common problem I come across has to do with the detection of thyroid nodules or growths within the thyroid gland. And these are nodules that are often found on palpation just with a general exam at your doctor's office, or they may be found as a result of some type of imaging study that's done, either a CT scan or an MRI scan that is done for reasons unrelated to the thyroid. And so when these patients show up in my office, they often will present both a diagnostic as well as a management dilemma. And the reason for this is that thyroid nodules are extremely common. It's estimated that in autopsy data, when they look at the thyroid gland, that up to 50% of people may have a nodule in their thyroid that's larger than a centimeter and have no evidence of any thyroid disease. Only about 4 to 7% of these nodules are actually able to be palpated or felt in the neck. So a lot of these are discovered incidentally. Thyroid ultrasound is an exquisitely sensitive test. It detects nodules of any size. And again, it's estimated that almost 70% of us, if we had thyroid ultrasounds, would have some type of thyroid nodule. The majority of these nodules are completely asymptomatic, and only about 5 to 10% of them represent some type of thyroid cancer or malignancy. And so that's where the dilemma comes in. You know, thyroid ultrasound is a very low-cost test. It's readily available, and it has a low, complication rate. There's really nothing to it. So sometimes patients will go see their doctor and they'll have a thyroid ultrasound which will pick up nodules in a significant number of patients. Or they may present to my office because they had some other type of imaging study that, again, showed a thyroid nodule. And so the question is, what do you do with it at that point? This has all been created somewhat of a relative epidemic of thyroid nodules that come in. And so we want to try to figure out a rational way to approach this, to figure out which ones can be watched and which ones, don't have to be treated. And as with any condition, we usually start with the history and physical. Most patients, again, come in because a nodule's been palpated or it's been incidentally found on some type of imaging study. And as I mentioned, the risk of cancer is low in the overwhelming majority of these. But there are certain things in the history that may make us more concerned or tip us off. And one is if the patient has had previous radiation therapy to the head and neck, particularly in childhood. If there's been rapid growth of that nodule, if it seems to be getting bigger quickly, if there's problems with swallowing, if they have hoarseness. Males are at greater risk for developing cancer than females. Thyroid nodules and thyroid disease are heavily predominantly female. So if a man shows up with some of these things, our interest is a little bit higher. If we find a nodule at the different extremes of age, if we find a nodule in somebody who's under 20 or somebody who's over 70, those kind of pique our attention. And also if there's been a family history of thyroid cancer, and in particular, one type of cancer called medullary thyroid cancer. On the physical exam, there may be some other things that alert us to a more serious problem. And one would be a nodule that's 4 centimeters in size or greater. If that nodule is firm when we feel it, if it's rock hard, that becomes more of a concern to us. If the nodule is fixed to the underlying tissues in the neck, that makes us more concerned. If there are associated lymph nodes that are enlarged, or there are other lumps or bumps in the neck, another factor that makes us worried. And if there's a paralysis of the vocal cord, that's a very worrisome sign and prompts us to look more closely. Most of these patients that come into my office that have a thyroid nodule are euthyroid, or meaning they have normal thyroid function studies. As a general rule, I do get thyroid function studies. Many times have already been done by the doctor that referred them to me. And the simplest way to evaluate matters is to get a TSH level. If that's normal, there may be no further testing that's done. If the TSH level is low, then I'll go on to get a T3 and T4 level to see if that patient actually is hyperthyroid. In about 10% of patients that have a nodule in their thyroid, if they have elevated thyroid function studies, it may signal just a solitary, what we call hyperfunctioning nodule. And the risk of malignancy in those cases is extremely low. And I will send those on to my endocrinologist to be evaluated and treated medically. Another lab that may be helpful is something called a calcitonin level. This may be elevated, again, in certain forms of thyroid cancer, particularly medullary cancer. In terms of imaging studies to evaluate this, by far and away, the most important test to us is a thyroid ultrasound. It's able to detect very small nodules. It can detect if there are multiple nodules. And more importantly to me, it may detect the size of the nodule and allow me to accurately quantitate whether this nodule is getting bigger over time. The ultrasound can also tell us whether there's other associated lymph nodes that might be enlarged, suggesting some type of spread of that tumor to the associated lymph nodes. And there may be characteristics on the ultrasound that tip us off, that make us suggest that this may be something more worrisome. If you have a solid nodule rather than a cystic nodule, that piques our interest. If there's evidence of increased blood supply or vascularity to that nodule, that makes us more concerned. If there are little microcalcifications within the nodule, that's often suggestive of a papillary carcinoma. If there are irregular margins that are evident, again, we become concerned. And my radiology colleagues are able to take a look, and often they'll notice that if there is the absence of a halo, usually if you have a benign nodule and it's well encapsulated, you'll have a little ring or halo around it, and if that isn't present, we become a little bit more concerned. But the ultrasound itself does not make the diagnosis. We can't make the diagnosis of a malignant versus benign nodule just on the ultrasound alone. And ultimately, we need some type of biopsy. And I'm going to get to that in a little bit. Some of you may have had thyroid scans done in the past. Thyroid scans are a test where they put some radioactive dye in there, and it is selectively taken up by the thyroid gland. And it has some limited use. It's able to detect whether this nodule that's in the gland itself is what we call a hot nodule or a cold nodule. And a hot nodule is one that takes up the radioactive iodine, and that constitutes about 5% of nodules that come into the office. And again, the incidence of malignancy is very low there. We can rest easier about those. About 85 to 90% of nodules that are found on thyroid scan are cold nodules. And of those, about 10% are malignant. And so the thyroid scan may help us determine if there's a hyperfunctioning solitary nodule, but otherwise it's not terribly helpful to us, at least in the initial workup of that thyroid nodule. CT scans and MRI scans really don't have a big place in the evaluation of the thyroid nodule. They are great tests to look at the size of the thyroid. And so if I have a patient that has a massively enlarged thyroid, and particularly if it extends down into the thoracic cavity or chest, a CT scan or an MRI scan gives me great information there, but it doesn't help me differentiate which are good and bad nodules. The same thing with the PET scan. That is a modality that's often used by my medical oncology colleagues to look for malignant disease or recurrent disease, but at least in thyroid disease, it doesn't help us determine bad from good. The most important step in the workup actually is what's known as a fine needle aspirate. And this is a test where a needle at the end of a syringe is used to puncture the nodule, and we try to withdraw or aspirate material to send to the pathologist. It is widely available. It's well tolerated. There's a very low risk to it. And the use of the fine needle aspirate has really helped dramatically cut down the number of thyroidectomies that have been done. And it also increases the yield of those thyroidectomies that have produced some type of malignant disease. It can be done with or without ultrasound, but the diagnostic accuracy is much better with ultrasound because you can see it actually going into the nodule. And again, if you try to do it without ultrasound, there's a chance that you may miss it. And even with larger thyroid nodules, even under ultrasound guidance, because of the size of the nodule, there's the potential for sampling errors. And fine needle aspirates are very helpful. They're not foolproof by any means. When we do a fine needle aspirate, we can expect that we're going to get one of 4 results given back to us. The aspirate can be read as benign. And in that case, there's probably only about a 3% chance of having a malignant cancer. And those patients usually can be followed with serial ultrasounds. And we'll consider repeat fine needle aspirate if that gland seems to be enlarging, or if there are findings on ultrasound that make us suspicious that this may be more worrisome than we thought. If we have a patient that has a fine needle aspirate and is given a benign diagnosis, and then there's a repeat scan or a repeat aspirate done sometime in the future and it's also read as benign, then the incidence of cancer drops down to below 1%. So those are very safe conditions. We can get a diagnosis of a malignancy. And there's only one thyroid cancer that can be diagnosed accurately with fine needle aspiration, and that's papillary carcinoma, because it has some cytologic features that make it very characteristic. There are other different types of cancers, such as medullary thyroid cancer, anaplastic cancer, lymphoma, poorly differentiated cancer, and metastatic cancer that also have been found on fine needle aspiration, but the diagnosis there is less common. It's not always as foolproof. We can also get a non-diagnostic aspirate. And as I said, it's not foolproof. Sometimes when the pathologist or radiologist does the aspirate, even under ultrasound guidance, there may not be enough of a specimen there to actually determine what it is. And usually I'll have those tests repeated at least one more time to see if we can at least shake that possibility. And then the last diagnosis that we can get with a fine needle aspirate is an indeterminate diagnosis. What does that mean? It means there are certain thyroid cancers that we can't distinguish with fine needle aspirate alone. And these primarily are follicular cancers and another category known as oncocytic cancers. And the reason we can't determine malignancy with these lesions is that you can only determine malignancy if the capsule of those nodules is invading the underlying thyroid tissue, or if it happens to invade into adjacent blood vessels or lymphatic channels. And the only way to determine that is to surgically remove the specimen and have the pathologist examine it underneath the microscope and look for those types of features. So when I get a fine needle aspirate that's read as a follicular or an oncocytic lesion, then there's about a 15 to 30% chance that those lesions are malignant. So armed with all this information, what's a reasonable or rational way to approach these things? We certainly don't want to be taking thyroid nodules out on everybody, and it's certainly not necessary. But we also don't want to miss the possibility of more serious problems. So in terms of a rational approach, generally, if you find a thyroid nodule on thyroid scan that is smaller than 1 centimeter, these nodules actually are difficult to aspirate even under ultrasound guidance. And usually we'll just follow these nodules, meaning getting annual or yearly ultrasounds and looking for any change in size or looking for any change in characteristics that might make us more suspicious. We may consider biopsy of something that's smaller than a centimeter if there's a significant history of previous radiation therapy, if there's a strong history of thyroid cancer, or if there were some features on the ultrasound. Many times in the workup, as I said, I will get thyroid function studies. They have limited value, but if I get a TSH and it's suppressed, and I get a T3 and T4 and they're elevated, suggesting that there's some hyperthyroidism, this is the one instance where I may get a thyroid scan to look to see if this is a hot or hyperfunctioning nodule. And again, those people have a very low risk of cancer, and you know, we don't do anything other than have them followed by the endocrinologist. Lesions that are a centimeter or bigger with normal thyroid function studies. The initial step should actually be a fine needle aspirate biopsy, usually under ultrasound guidance. And if that biopsy is benign, we usually will repeat the ultrasound again in 1 year and consider repeat fine needle aspirate if it's getting bigger or if there are changes on the ultrasound findings. If we get a fine needle aspirate that's read as malignant, then we should be prepared to go in and do a total thyroidectomy. And the ultrasound in this case should also be used to look for evidence of any enlarged lymph nodes or lymphatic spread, because that may be part of the surgical treatment plan. Total thyroidectomy implies complete removal of all thyroid tissue. And it is the treatment of choice for those people that have documented parathyroid carcinoma, follicular carcinoma, Hürthle cell carcinoma, and medullary carcinoma, which are the major forms of cancer that we come across. If we get a fine needle aspirate that is non-diagnostic, or if it's indeterminate, what we usually do in that case is we suggest to the patient that they have an elective thyroid lobectomy, meaning we take out the half of the thyroid that has the nodule in it, and we send that nodule for what's known as frozen section diagnosis, which means intraoperatively, I take this nodule out, I send it to my pathologist, and he looks at it. And probably 90% of the time, he can make a determination about what the findings are. If that specimen is read as benign, we're done. We close things up and we're finished with the operation. If it's malignant, then I have to be prepared to go on and take out the whole thyroid gland. And in about 5 to 10% of cases, the pathologist is going to come back and tell me that he's not sure. And in that case, I have to stop. If we wait for the final pathology diagnosis to come out, which may take a few days. If that final pathology diagnosis is malignant, then we have to go back in and do a completion thyroidectomy. Patients aren't excited about that. As surgeons, I'm not excited about that, but we usually have to do that, within a month or two after the initial procedure. The one exception may be if the patient has a centimeter lesion or less that is a single focus of cancer and there's no evidence of any lymphatic spread or spread of it beyond the thyroid gland itself. In that case, we may just end up doing the partial thyroidectomy and monitoring those patients very closely. I hope I haven't confused things too badly at this point. Questions?